Okay, all right. Good morning to all. Good afternoon for those who are here in Europe. I'm Ski and I'm a nurse coordinator from Bambino Gesù Children's Hospital, and I'm also WFPICCS Nursing Vice President. And I'm really delighted to welcome you to this first WFPICCS Nursing Webinar of the year, where we will explore an increasingly important topic on optimizing nursing workforce policies to transform pediatric critical care. So a warm welcome to all of you, and thank you for joining us. Today, we will discuss how workforce policies shape PICU practice, and we will share best practices. We will address some global challenges and explore innovative solutions to optimize workforce strategies in PICU. So we really look forward to this webinar and to the presentations of our speakers and to a very engaging discussion. We will take questions at the end, but also during the webinar. Please write your questions on the Q&A and please direct your questions to the WFPICCS office so that we can then pose them to the speakers. And I'm really delighted to introduce my co-moderator, Bistra, Zheleva, who is also Vice President of Global Strategy and Advocacy at Children's HeartLink. So thank you, Bistra, for co-moderating with me, and I leave the floor to you.
Thank you. Thank you so much, Orsola. As Orsola said, my name is Bistra Zheleva. I work at a nonprofit organization, an NGO called Children's HeartLink, that is focused on building capacity for pediatric cardiac care. And a big part of our work is really developing capacity in the ICU for children who need cardiac surgery, hence my interest in this topic. I am a member of the Pediatric Cardiac Intensive Care Society, the PCICS, which is a society dedicated specifically for intensive care for critically ill children following pediatric cardiac surgery, which is also a member of WFPICCS. And so we have joined forces to focus on this important discussion because, as we all know, I'm sure if you're here, you believe nurses have an integral role in the intensive care unit and providing intensive care services for critically ill children. And we've brought together a few interesting presenters who will speak about different topics that all relate to policies, health policies for nursing care. And I wanted to start with our keynote speaker, which is Lisa Little. She has generously agreed to join us and speak about the work that in the International Council of Nurses is doing. Lisa Little is the first vice president of the ICN, and she represents North America and the Caribbean on the ICN. We will put every presenter's bio in the chat box so you can read it, so we don't spend a lot of time talking about that. But as you can imagine, you must be quite accomplished in order to have the role that Lisa has. So Lisa, the floor is yours, and please, she will share a little bit about the global policy engagement that the ICN has. So I will go ahead and mute myself, and Lisa, please, the floor is yours.
Thank you very kindly, Bistra, and thank you for the invitation to join here today. I'm just going to pull up my slides. I do have a deck that I want to share. So can everyone hear me okay?
We can hear you very well.
Excellent. I'm just going to go
into see your slides.
View for a second. Is that good?
Yep. This is perfect.
Okay.
Thank you. Go ahead.
Great. Thanks very much. So I wanted to share with you a little bit today about some of the resources, both within ICN and globally, that may be of use to your work in terms of looking at the workforce in pediatric critical care or intensive care. I am a former adult critical care nurse, actually, in my clinical time, no longer do that, but so I can appreciate the environment that you work in, and it's probably even more emotionally and stressful when you're dealing with children, not something I ever wanted to endeavor with. Adults were enough for me. So I appreciate it. And I really thank you for all the work that you do globally with children. An important piece of work. I wanted to start by talking just briefly about ICN. So ICN has 130 national nursing associations around the world. We are nurses representing nurses, so our board is all nurses. We represent the 28 million nurses around the world. We are the first NGO, non-governmental organization that was recognized by the World Health Organization and founded in 1899. Not only do we advocate for nursing to bring forward the value value that nursing brings healthcare, but also try to influence health, social, economic, and education policy. As we all know, it relates to the social determinants of health and impacts people's overall health in the end. This is a picture of the ICN board in 1900, and then in 2023. We will change boards again in 2025 in Helsinki. It's a 4-year term on the ICN board. I'll complete actually 2 terms of 8 years, and that's the max you can do. So I'll be stepping down, and there'll be elections for new board members, and they go by region. If you're ever interested, you should consider running for the ICN board. It's a great opportunity, and it'll happen again in 5 years or 4 years from now. I want to just start by sharing with you, and these are from the WHO, some of what they feel are the state of the world's health, and ICN has looked to them as well. But I want to ask you what you don't see here. You see nothing about children. So one of the biggest things is to get, your issues on the radar. When you want to think about improving workforce issues, you need to get the attention of policymakers, decision makers, employers. And I would urge you to think about the NCDs in terms of cancer, heart disease, and other ones, which are top of mind for people that represent 71% of deaths globally. And think about, what percentage of those are children? What percentage of the deaths annually are children? What percentage of ICU admissions overall are children? So again, needing to raise the issue to get support and investment in pediatric nursing workforce starts at the very top of getting this on the radar of organizations like the WHO and within your own countries. And we all know that health is a privilege, and health is not a privilege, but is rather a human right. And that there is no health without a health workforce, and particularly a nursing workforce, because we are the largest portion of the health workforce, and that of course includes pediatric critical care nurses. Workforce shortages are now the greatest immediate threat to global health and patient safety, thanks in part to COVID, but not just COVID. We knew that there was existing global nursing shortage before COVID happened, and what we've seen is a snowball effect then of the previous shortages, which included a lot of underfunding of health services, poor pay and working conditions, and then the pandemic hit. The COVID effect, has been clear. It's been well documented, and ICN has tried to capture that in a number of our documents that we've released. But we don't know yet the scale of the impact on the nursing workforce over time. We know that 80% of our national nursing associations report mental distress among their members. We know there are widespread reports of exhaustion, anxiety, fear, isolation, burnout. There are nurses with PTSD. There are nurses with long COVID. We've seen suicides as part of the outcome of the COVID pandemic in nurses. So all very sad of what's happened on top of what was existing before with our workforce. And now we have a new dimension. The conflicts around the world are leading to violence and attacks on nurses and other healthcare workers and healthcare facilities. Attacks on healthcare facilities have increased by 75% in the last 3 years. And there have been more than 1,000 healthcare worker deaths since 2022. A whole new level of impact on the nursing workforce. And ICN has been very active on this issue in terms of our advocacy on behalf of our members, calling for that these are violations of humanitarian laws and conventions, and about needing to safeguard healthcare facilities and the personnel in conflict zones. So the nursing shortage, how big is it? There are numbers out there. You may have seen some of them. They range from, and they've changed over time as we've learned more and more. So we had numbers before the COVID impact that we're putting it at about 18 million healthcare worker shortage by 2030. We released the first ever with the World Health Organization State of the World's Nursing Report in 2020, which estimated the shortage about 6 million. Then we went through and saw the effects of COVID. And so you'll see other numbers out there. In fact, all the way up to 30 million nurses are needed, which was a study done in 2022, which really looked at if we were truly to meet universal healthcare coverage levels, how many would we need? And that's where they got to the 30 million. ICN's best estimates now put the nursing global shortage at about 13 million. and that's a crisis. The dimensions and contributing factors of the shortage vary, but they are common among some countries, many countries around the globe. Some are very unique to certain regions or specific countries. And among your own specialty, I imagine that there are some that are the same globally and some are different depending on where you are in the world. And these are what we heard from some of our members, so those national nursing associations, in terms of we're not producing enough nurses to begin with our own domestic supply in each country, and we're reliant on overseas educated nurses to fill their workforce gaps. 90% of our NNAs surveyed reported, as I said, that they're extremely concerned for the nurses' workload, insufficient resources, burnout, and stress. 1 in 5 countries reported an increased number leaving the profession. And in terms of salary, they reported to us that their pay rates have either remained flat or decreased in real terms according to cost of living and inflation rates. So not a great situation globally for the world to be in. But there are some solutions, and those solutions lie in the strategic directions for nursing and midwifery. These have all been adopted at the WHO or the World Health Assembly by all countries around the world. And there are 4 pillars within this that require action. There is no one quick fix or policy solution within each one of them that's going to solve the global shortage. So they're related to jobs, education, leadership, and service delivery. And if you hadn't had a chance to read that, it's a pretty simple read. It really talks about what's needed in all 4 of those areas to turn the tide on the nursing shortage that we're experiencing. To support those strategic directions, ICN has released several workforce reports in the last few years. I mentioned the State of the World's Nursing Report, and there's a new one coming again this year, actually soon, in May. In 2022, we released Sustain and Retain and Beyond, and then in 2023, we released Post-COVID, the Recover to Rebuild. If you haven't had a chance to view those, I encourage you to do so. I just want to touch on a few points out of them. In the 2022 report, ICN released a 10-year blueprint for a better future and what could be done nationally and what should be done internationally. And the recommendations in this report really apply to the nursing workforce as a whole in each country, but also to specialties like pediatric critical care. In the 2023 post-COVID recovery to build, that's when we arrived at the 13 million shortage post-COVID, based on the numbers that we had seen, what was reported, where the gaps were, etc. And what we found was that the impact of the pandemic, of course, was continuing and worsening, and that the health demand is increasing and the nurse supply gap is widening. So there's the supply is going down and the demand's going up, and so the gap is increasing. And that is when we really started to talk about the language of a global health emergency. The report also highlights the situation, as I mentioned, for the workforce post-COVID, and really the impact of not only on the workforce, but then on patients and patient safety. And so there were reported rates of intention to leave by more than 20%. Nurses were leaving actually by increase by 10%. And some of the things I talked about, the moral injury and still not feeling being listened to, etc. And we really tried to come out at that point and talk about, we talk a lot about nurses' resilience. This is not about nurses' lack of personal resilience. This is about organizational and system failure to protect and prevent harm to nurses and ultimately then to the clients that they serve. So we're really trying to shift the blame for this about, well, nurses aren't resilient enough and nurses aren't strong enough. No, that's not the case at all. This is all about what systems have done to nurses and organizations have done to systems. Sorry, my mouse moved. Another key resources that we would encourage you, if you haven't had a chance to read, there's a white paper that we did with the Saudi Patient Safety Center on nursing staffing levels and their impact on patient safety and the workforce safety, your own safety of nurses. We also have a position statement on evidence-based safe nurse staffing that, again, is helpful for you. We have a position statement on patient safety. All of these we try to build in the latest research, etc., so that you have the ammunition, if you will. You have the evidence. You don't have to look for the evidence. You can use this in your arguments, your discussions with your employers, with nursing leadership in your countries when you're talking about what safe staffing looks like in the pediatric critical care world and what we need, or what it means then for patient safety when we don't have enough pediatric critical care nurses. So I appreciate it may not be specific to your specialty, but I think there's general inferences that can be used and made if you want to use these, and they're all available on our website, of course. And all of this experience over those years led us to really our IND, the International Nurses Day report in 2023, where we launched a new campaign, Our Nurses, Our Future. And we came out with the Charter for Change, which is 10 points, which we've really continued to embrace today. And you'll see us continue to do that. Again, where we feel these are the steps needed to value, protect, and invest in our nurses so that we can have a sustainable future for nursing, but also for healthcare. I want to just touch on a few of them just briefly to talk about. The first one is about protecting and investing in the nursing profession. And that really comes back to countries implementing those recommendations in the strategic directions for nursing and midwifery. And it really requires that to rebuild health systems so that we can meet our sustainable development goals and universal health coverage, really. And so we're really pushing for all countries to have a plan to implement that within their own countries. Number two is really about working conditions, safe and healthy working conditions, and respecting nurses' rights. So this talks about safe staffing levels, what that means, what that looks like. In a pediatric critical care, is that 1-to-1? Is that 1-to-2? Setting those standards and levels that are based in safety and evidence, but also things like zero tolerance for violence and making sure you have the right protective equipment to do your job is really important pieces of this one here. It's also about labor laws too, as well, about occupational health and safety. So there's all kinds in that we refer to and talk about. Next one is about pay and positive practice environments. It's really about providing appropriate compensation and benefits. It's about supportive practice environments that encourage continuing education, that you have the tools and resources to do your job, and that you have a voice in the decisions that are made about care in your organization or within your country, and that nurses are appropriately, recognized for the work that they do and valued for the work that they do. Nothing of this is surprising for you, I'm sure. It's things we've talked about over the years, but we've tried to consolidate into something, as you know, that's easy and contained and we can refer to and move forward on. The fourth one is really about developing, implementing, and financing national nursing workforce plans. So I don't know if you're aware whether within your countries you have a national nursing workforce plan. Do you have a workforce plan for pediatric critical care nurses? And what does that look like? So really talking about collecting data, making sure that you're starting to produce more nurses in your own country so that you don't rely on recruiting from others. Our big focus on retention, we can continue to produce, but if we don't keep them, we all know that it's like Swiss cheese, they're just falling through the holes, right? So many things around that and what that looks like. We know from decades of research that there are a number of nursing sensitive outcome indicators. One of them in hospitals is hospital-acquired infection rates. And we know as well that critical care units can be of concern when you've got a child or an adult, with 10 or 20 lines running into them and all kinds of breaks, in the surface of skin. All of these are potential sources of infection. And we know that better RN staffing levels lead to lower hospital-acquired infection rates. We have decades of research on that. But even more importantly, research shows that for every US $1 spent on preventing healthcare-related infections, there's a return on investment of $7 US. So it's 7-to-1. Those are the kind of numbers that employers and organizations listen to. As we say, money talks, right? And this is the kind of an economic research that really speaks to the need for investing in nursing. And this is just one of the nursing sensitive outcome indicators. You can imagine if we added them all up, what the return on investment would be. And it's two sides of the same coin, right? So investing in nursing also improves nursing safety and the things we've talked about, but also improves patient safety, as we've talked about. So huge economic savings to be achieved through appropriate staffing levels within nursing. Unfortunately, oh, and sorry, this was the safe staffing one. Yeah. So there's more information in this one on the safe staffing levels that I referred to. The onus, or not the onus, I guess the trend is for some policy and decision makers to think that a registered nurse can be substituted with less educated nurses these days, or less educated healthcare workers, where it's all about substitution, trying to find a cheaper source of employment. And that is not the case. So the cheaper is not better. And the position statement that we have on the evidence-based safe staffing really talks about this, and talks about that RNs must not be substituted with less qualified cadres of workers. And I encourage you, and we all do, to keep sending that message as they try to replace. Now, we can be complemented in the team with other types of workers, but no one can replace the work that an RN does. And in critical care especially, there can be no substitution, or anywhere, in fact. So I encourage you to think about that again, how to use that. Our IND report for 2024, The Economic Power of Care, really builds the economic business case for investing in health and nursing. So again, if you haven't read that or glanced through it, there's some really great examples to use. And this is the 1 in 7 that I referred to around for the hospital-acquired infection rates. As you think about workforce planning for your specialty, in addition to the strategic directions on nursing and midwifery, you may want to look at the WHO Global Strategy for Health Human Resources report, workforce report. It offers a framework and policy levers about ensuring a sufficient number of nurses to meet population health. And you can adapt this to your own context within pediatric critical care nurses, thinking about how many do you have within your organization or at a country level or regional level. What are their ages? Where do they work? Are they employed full-time? Are they part-time? Have they left the workforce? Could you bring them back? Are they working to full scope? Are you having appropriate staffing levels? Are you providing them with all the tools and resources they need to enhance their productivity, so they're not running around looking for wheelchairs or running around looking for, medicine? And then on the population side, you might think about how many pediatric admissions, critical care admissions, are we seeing in a year at our organization? Is that going up or down from previous years, right? What are the ages of those children? What is the reason for their admission or how long are they staying? Are they getting, infections in here? So all of those things can help you build the business case to understand and plan for how many critical care nurses and peds are needed, either at an organizational level or at a country level, over time, when you start to look at trends and how things are looking. So just some food for thought for you to think about if you haven't already kind of examined these types of things. Pediatric critical care nurses are not born right out of nursing school. We know that it either comes with many years of experience, or you may have taken a specialty certification course and now have a specialty certificate. And when we think about investment by governments and employers in specialty nursing, we think about their investment in specialty education. Does your country support and have specialty, pediatric critical care courses, for example, for nurses to take? Do you have a specialty certification program in your country for pediatric critical care nurses? And are there provisions in your labor contracts or your collective agreements, whatever you'd like to call them, that give you a financial bonus for having that specialty certification or having that specialty education, right? So all of these are things to think about when you think about countries investing in nursing, and particularly as it relates to specialty nursing. I just want to wrap up with, there's a new IND report, International Nurses Day. This year's report's coming out on April 16th. And it really focuses again on caring for nurses and how it strengthens economies. Again, there's going to be a lot of economic data in there, but really focused on how we support our nurses, their health, including their mental health and other aspects of their career. And finally, I hope to see some of you perhaps in Helsinki for the ICN Congress, June 9th to the 13th. It's going to be a great event. I think we have over 6,000 nurses registered now. And as always, it's a tremendous personal and professional, I think, enrichment to our careers. So hope to see you there. And thank you again for the opportunity to share with you today.
Thank you so much, Lisa. Orsola will introduce the rest of the speakers, but I think this is so important, what you were just sharing. I was taking notes because we're constantly trying to impress the importance of nursing care and critical care specifically. And everything that you said, I think, can be useful to many of us. I'll give the floor now to Orsola to introduce our next speakers. Thank you so much, Lisa, for being here.
Yes, thank you so much. And I'm sure there'll be questions for you along the way. Many thoughts. However, for example, I was thinking of the nursing substitutes, which unfortunately is something that is happening a lot in Europe, particularly in our country. So yes, we need to be together and to network and make sure that the policies guide us in supporting us in facing those challenges. Yeah. Thank you so much. So I will introduce the next speaker is Tiffany Mullen. Here she is. So thank you, Tiffany, for being here with us. And Tiffany is a clinical nurse specialist from the Children's Mercy Hospital in Kansas City. And she's also the secretary for the American Association of Critical Care Nurses. So thank you for being here, and we look forward to your presentation.
Thank you so much. Okay. Can you see my screen okay? All right,
Yes,
great.
we can.
All right. Well, thank you for having me. I'm going to dive right into talking about optimizing the nursing workforce policies to transform pediatric intensive care unit from the American Association of Critical Care Nurses perspective, which is the organization that I am representing today. So a little bit about the American Association of Critical Care Nurses in the United States is that we are the world's largest specialty nursing organization, serving over 130,000 members throughout the lifespan. And the AACN organization offers education, certification, publications, and countless initiatives supporting acute and critical care nurses to provide optimal care to patients. So I'm going to talk about a few of these initiatives specifically related to pediatric and staffing. There we go. All right. So Lisa talked about this a little bit in her presentation, and so it feeds in nicely to the work that AACN has done and just speaks to how important healthy work environments are to staffing. Appropriate staffing is only achievable if we have healthy work environments. AACN identifies appropriate staffing as one of 6 standards for a healthy work environment. And to address staffing deficits without also addressing underlying issues in the work environment is like pouring water in a bucket full of holes. You're not going to have any forward movement unless you address all the holes, not just the one that is specifically staffing. So we must address the health of the work environment to achieve appropriate staffing. We know that ensuring work environment is healthy, that the work environment is healthy, is a key strategy in retention of nurses, which again is something that Lisa mentioned in her presentation as well. We have seen through our data over the years that nurses who report that their unit implemented these healthy work environment standards also reported less intent to leave and less moral distress. All the things that keep nurses at the bedside taking care of the patients that we see come through our doors. Staffing is one of the standards, but it's not more important than the other 5. Because it's been one of the lower scoring standards on our survey data through the years, we've dedicated a great deal of resources to improve staffing, but it doesn't mean that it's more important than the rest. They're all inextricably linked to one another. ACCN first published these 6 healthy work environment standards in 2005, and then they were revalidated and republished in 2016. And since 2005, we've collected data through national surveys, created a free online assessment tool to help units measure their environments and see where they are within these standards. And then we've also offered educational resources such as webinars, blogs, and then of course, healthy work environment is a huge point of our annual conference called National Teaching Institute that we hold yearly. Starting in 2023, we began 3 programs to advance implementation of these standards even more. There was a national collaborative with 44 hospitals that are focusing on healthy work environments. We have 7 cohorts, which also have 10 units within each of those 7 cohorts of our Clinical Scene Investigator Academy that are looking at specifically the work environment and staffing. And then we also have a Nursing Innovation Grant Fund in partnership with the American Association of Retired Persons, or AARP. And there's a QR code, and I can share the links in the chat as well of the resources that I am talking about throughout this presentation. So as previously mentioned, since implementation of the Healthy Work Environment Standards, the staffing standards tend to score lower on the surveys. Therefore, AACN has dedicated quite a bit of resources and and effort to this standard. And because a collaborative voice is stronger than an individual voice, just what we're doing here and getting together and learning from others, collaboration is essential in moving the staffing work forward. Professional organizations listed at the bottom of this slide here convened in January of 2022 with work through March of 2022, or 2023, I'm sorry. And this was the Nursing Staffing Think Tank. These partners addressed what can we do right now about staffing, and it resulted in a practical consensus around the priorities, recommendations, and actions to address the staffing crisis. And this was at the organizational level. From that work, the Nurse Staffing Task Force was convened in April of 2022 with work going the next year. And this Nurse Staffing Task Force addressed ongoing barriers specifically to appropriate staffing. The results represent a collective expertise, including some recommendations for regulatory, policy, and payment structures. And this work really aimed at regional and national level changes. Within both of these bodies of work, the recommendation that came from both of them is that specialty nursing organizations are really in the best position to create standards for their patient population. So AACN did just that, and we serve acute and critical care nurses for the patients throughout the lifespan. And so they took these recommendations and we created a specialty staffing standards. The QR code that you see on the slide here will take you to our standards for appropriate staffing in adult critical care, which was published in April of 2024. And we are all here because we're pediatric clinicians and are here for the pediatric population. But as we know, a lot of the pediatric evidence is extrapolated from adult evidence, or what starts in the adult population kind of trickles down to the pediatric world. So that's why I'm going to share a little bit about these staffing standards. And I also wanted to share that currently by the end of this month, we will be publishing our standards for progressive care. And then AACN is working on specific pediatric critical care staffing standards, which I think is really exciting, and I'm ready for it in my workplace. The organization has begun by gathering insights from our community of members through a focus group and then also surveys to over 400 nurses who responded from the bedside, and we'll incorporate those insights into our next steps for the pediatric critical care staffing standards. So just like we can transfer and extrapolate information from adult literature, I'm going to go over the staffing standards for the adult critical care just to get a little taste of what may or may not come from the pediatric staffing standards that we're working on currently. And they also used the same kind of process of really looking at the insights of people at the bedside and what do we actually need from these staffing standards. So all these insights are incorporated from actual people doing the work, which I think is really important. So in this version that we have published, there are 7 standards, and each has specific, let me see if I can move that, there we go. Each has specific examples, exemplars, actions, and resources connected to each of the standards. They build on and refer to the think tank work and the task force work, while also specifically addressing critical care. And in this case, adult critical care. Standard 1, as you can see listed on this screen, is foundational. It's stating that direct care nurses participate in all aspects of nursing, so getting their voice at the decision-making levels. This includes planning and evaluation through formal pathways like shared governance, and then informal channels such as ensuring that there's a culture of psychological safety within the working environment. Standard 2 and 3 address the way that clinical leaders on the unit make patient assignments, because they know what their patients need and what the nurses have to offer for those patients to make the needs fit the nurse. This can be done with the development of unit-specific staffing guidelines and use of validated tools to measure those workloads that can vary in different environments and inform patient assignment decisions. Standard 4 addresses the role of the clinical leader and that they do not carry a patient assignment while in that role, so that they can focus on the needs of the unit. Standard 5 describes how staffing plans provide support for needs of nurses who are new to the unit. And you may be asking, well, what about retaining our experienced nurses? New nurses were specifically called out in these standards because of the escalating early career turnover. So based on the insights that we get from pediatric nurses, it may or may not look like that in the pediatric critical care staffing standards. We'll just have to wait and see. It would be interesting, I think, in this venue to hear if this is a worldwide experience from the pediatric perspective of, are we really focusing on, are we really seeing in the data, we're trying to get new nurses, or are we trying really hard to keep our experienced nurses? So I think that would be an interesting perspective worldwide to see if that is the same everywhere. And then standards 6 and 7 address the role of organizations. Specifically, standard 6 states that staffing plans support a healthy work environment from the organizational level. And then 7 states that organizational staffing plans should anticipate the need for a critically ill or injured patient, require at least 1 nurse per 2 patients. So really supporting that from the organizational level, that critically ill patients may need those 1 nurse to 2 patients. So where do we go from here? I think everyone attending this webinar is taking a huge step in learning from others. At AACN, we have seen the benefits of sharing stories and pearls of wisdom with others. And on our website, there's an entire page dedicated to this. The page has stories of innovative ideas that have been implemented to achieve improved staffing from others. And those stories, there's stories about recruitment and retention. There's stories about supporting new nurses, experienced nurses, implementation of acuity tools or nursing staff ratios, and so many more studies, stories, and angles that different areas have taken. So hearing what others are doing may not be feasible in everyone's workplace. Maybe we don't have the same resources, we don't have the same manpower or abilities, but what you can do by hearing stories from other places and success stories is take 1 or 2 pieces from that and see if those would work in implementing in your place and improve what your gaps are in your area. I want to thank you guys for this opportunity. I look forward to the questions and I look forward to the other presenters, and a special thank you to Sarah Delgado. She has been integral on the AACN staff in all of this work, and if anyone has specific questions, I'll probably direct you to her. But I look forward to the next speakers.
Thank you so much, Tiffany. This was fantastic presentation. I'm making notes of everything that you said. It complements so well a presentation by Lisa, which was very high level global. You're talking about the experience from the United States. I really think this was very, very interesting. Just had a comment, but I think that Orsola will be introducing our next speaker.
Go ahead if you would like to.
No, please go ahead, Orsola. Please go ahead, sorry.
Yeah, okay. So I'll introduce the next speaker, which is Lauren Sorce. So more of the experience in the United States. So welcome, Lauren. Lauren is a very experienced nurse and nurse scientist from Cury Children's Hospital in Chicago. And she's also the immediate past president of the Society of Critical Care Medicine, and a lot more. I mean, she mentors researchers and oversees clinical research and much more. So welcome, Lauren.
Thank you, Orsola, and thank you to WFPICCS for inviting me to speak at this really important conference this morning. I'm going to talk a little bit about what things are happening from the FCCM perspective. So before I do that, I think it's important to look specifically at sort of the state of nursing in the United States, recognizing everything that Lisa's already told us about the current state internationally. But there's 1.75 million nurses that are employed in hospitals in the United States. So that includes all of critical care and acute care nursing. This is a survey that was done by NSI Nursing Solutions that included 450 hospitals, 37 states, almost 1 million healthcare workers, and almost 250,000 nurses specifically. And the healthcare vacancy rate, though nationally, is almost 10%. Hospital vacancy rate is as high as almost 16.5%. I think it's critically important to think about the dollars that this spends in our hospitals. And there are dollars spent in hospitals around the world that are related to the cost of turnover for nurses. And in the United States, the cost of turning over 1 nurse is $61,000. And for every 1% change in turnover that a hospital experiences, either in a reduction in turnover or an increase in turnover, it either costs or saves the hospital almost $300,000 per year. So that's an incredible amount of money that hospitals are either losing or saving based on the percent turnover rate. It is also notable that the survey showed that it requires hospitals, it takes them 83 days to recruit a nurse into the hospital, which is a substantial amount of time when you're thinking about nurse staffing. So why are nurses leaving their jobs? We know this, but just to put it up there, so there's personal and work-related reasons. I think consistent with what Tiffany just talked about, the healthy work environment, scheduling conflicts, salary, the commute, working conditions, workload, and staffing ratios. But nurses leave really for their own personal reasons too, including relocating, having more opportunities for career advancement, as well as just retiring in education. It's notable that in the United States, by 2030, so in just 5 years, there will be a huge efflux of nurses from the baby boomer generation that all meet retirement age. So this is going to be a huge problem. So I'm here representing the Society of Critical Care Medicine. And who is the society? So we're an international multi-professional society that's dedicated to the provision of activities that ensure excellence in patient care, education, research, and advocacy. I think it's super important for me to identify that we don't represent a single professional group, but really our focus is on the multi-professional team. So recognizing the importance of all members of the team, elevating everybody together so that we can provide this excellence and outcomes for our critically ill and injured patients. So how do we do that? So we do that through collaboration, as you just heard from Tiffany. AACN is working on the healthy work environments. So we collaborate with a group called the CCSC, the Critical Care Societies Collaborative, that includes us, AACN, the American Thoracic Society, and CHEST, to advance collaborative missions across all 4 societies, which includes the healthy work environment. We also do this through education, including what's called our fundamentals course. It's bringing all members of the ICU team to the bedside to learn together. We learn together at our yearly Congress, as well as our ultrasound courses and many of the other courses that we offer. Keep in mind, none of these courses are specific to an individual professional group, which is the beauty of our program. Research, we provide grants to members of the multi-professional team, and we have an infrastructure for the provision of grants as well, including data support and what have you. I think everybody knows that FCCM produces multi-professional clinical care guidelines. There's not a guideline out there that doesn't include the members of the multi-professional team as authors. It's critically important for us to bring all viewpoints into those guidelines. We recently launched what's called the Centers of Excellence, where hospitals can participate and receive formal recognition of integration of what is called the A to F bundle as standard of care, and then they receive for how well they're doing on that. So let's talk about membership. So FCCM recently rolled out tiered membership opportunities for different geographies around the world based on where the country falls on the World Bank. So as you can see, there are 4 tiers with different levels of membership within each tier, costing a different amount for nurses. And nurses fall into the healthcare professional. So it's either as high as $92 a year for the lowest level of membership, or as low as $5 a year for countries that fall in the World Bank Tier 4. And it's a very simple thing to go to the website to find what tier you're in and then apply for your membership there, as well as be able to identify what level of membership you're interested in receiving, from the associate to the professional to the one that includes all the membership perks at the select level. I really wanted to let everybody know that FCCM has received a grant from BDE to provide free fundamentals courses in areas of need around the world, and that will be on our website soon. So during the pandemic, we had a grant from Edwards Life Sciences and provided a number of free fundamentals of critical care across the world. So a couple of things are in progress. Because FCCM is an international society, we have our first international office that's been present in Beijing for a number of years. And we're opening our second office in Dubai. And those contracts are due to be signed soon. And hopefully that will be opened within the next few months. So it's about providing services to areas around the world where there's need. We are also investing in a new fundamentals course that targets bedside nurses and technicians. Orsola already made a comment about non-nurses at the bedside. And so if that's what's happening in areas, we want to be sure that we're providing education so that They know what they're doing, even though we recognize that perhaps that's not the best provision of care. Making sure that they're educated and contributing to outcomes as opposed to contributing to patient harm is very important. I wanted to end on this, which is not specifically related to the Society of Critical Care Medicine, but in November of 2024, the group of authors that you see here, led by Martha Curley, who many of you know, and you'll see that I am also an author on this paper, set forth this manuscript. That's the call to action, a blueprint for change in acute and critical care nursing. And the intent of this paper was to identify that nursing outcomes for years have been measured, but in the absence of nursing. So we've looked at all the harm metrics, and that's what's used to measure nursing outcomes. So things like bodies and collapses and pressure injuries, that's when nursing doesn't happen, as opposed to when nursing does happen. And so this paper outlines domains of nursing practice, as well as assumptions for organizations, and then the system and organization outcomes as they relate to changing. And so our belief is that when we start measuring actual nursing outcomes and not the absence of nursing, that we will improve recruitment and retention. I mean, who wants to go to work and see how bad your unit is because you have so many or X number of CAUTIs and CLAPSIs? Wouldn't you rather know that you had 700 admissions this month and 700 out of 700 patients did well? So I think it's a really important way that we need to start thinking about the way that we measure the impact of nursing on our patient outcomes, because until we do, nursing will remain in the background without a voice at the table. So I can put a link to this open access article in the chat. And for that, I would like to thank you for your kind attention and be happy to entertain any questions in the chat or at the end. Thank you.
Thank you so much, Lauren. I mean, really interesting. Please, yes, you can have the link of this great paper on the chat. It would be helpful, I think, for several people in this group. And
Happy to share it.
yes, very interesting also the perspective of focusing on nursing outcomes and seeing the positive, what needs to change in the positive attitude instead of what's missing. Yes. Fantastic.
Thank you, Lauren.
Thank you.
Thank you. Very interesting. Fantastic to think about not how to blame people, but how to make them feel good about their work. So our next speaker is Bruna Cury. Bruna is a nursing leader, a pediatric cardiac intensive care nurse from Brazil. Her bio will be in the chat. You will read more about her fantastic career so far. She will be speaking how the Pediatric Cardiac Intensive Care Society is launching and doing some work to support low and middle income countries and other countries in general, the world, to promote pediatric cardiac intensive care. So Bruna, the floor is yours. I think you're muted. Yes.
Can you see my screen on presenter mode?
It's starting, and you can just maybe start. It seems like it's taking a little bit of time, but you can start presenting. We can see the slide. The first slide.
Okay, I'm gonna start then. Thank you very much. Hello, everyone. I'm so honored to be able to speak today. Thank you so much for inviting me. My name is Bruna Cury. I am a nurse manager and international liaison at Cardioped Brazil in Brazil, a pediatric cardiology service for more than 25 years. We are partners with Children's HeartLink since 2009. And recently we were certified as Children's HeartLink Center of Excellence.
We still see the presenter mode, and I think now it's going to.
Oh,
yeah.
Sorry.
If they're helping you there, yes, we're seeing the presenter mode, not the presenter mode, but the presenter view.
Yeah.
Yes, exactly.
Let me see if I can change here. Yes, I think this is the one. Is that better?
It's starting now. Yep. Nursing staffing.
Okay.
Yep. Go ahead.
All right, perfect. So I'm going to talk a little bit about nursing staffing in Brazil, just a touch, because I know there will be presenters on nursing staffing in other parts of the country. But this is how we have been trying to better our processes regarding that. One of our biggest challenges that we face is inadequate staffing. And this is not just a problem in low and middle income countries, of course. It's a global issue, as we could see here with the speakers and what we face going to meetings and all. But in Brazil, just as a side note, we usually have 2 ICU patients being cared for one nursing professional, and usually they are preferred to have nursing technicians because of cost and instead of registered nurses. And this is very challenging due to the lack of educational preparation of these professionals to take care of such critically ill patients. In our service here, with the help of Children's HeartLink, we have learned that no expensive equipment can replace a well-trained team member, especially nursing staff. So we have been investing a lot in human resources in our nurses. So we were able to increase our staffing nurses and increase the amount of registered nurses as well in the place of nursing technicians after showing our hospital leadership that we can't compare the work of a pediatric cardiac intensive care unit nurse to a neonatal ICU, for example. The realities and complexities of patients are completely different. And we were able to increase and improve that through the nursing activity score tool to show how many more nurses we needed. And we're thankful that we have been able to increase a little bit our nursing staff, but we still think that we need more. There's a new tool called Cameo that's being studied in the US, led by Boston Children's Hospital, that's being designed to help assess ICU needs and nursing needs more specifically. And we are very excited to soon be working with them to test it here in Brazil as well. We know that the lack of professionals is not just a nursing issue. It is a responsibility that must be shared across the whole interdisciplinary team and the interdisciplinary leadership. Since we heard, ACN talk about this, but about the healthy work environment and how it is very important for nurses to feel engaged and valued. It is essential for the team to recognize their importance and create an environment that they feel safe and they can share, their difficulties and challenges while in patient care. So this is something that, unfortunately, through culture, we have to work on a daily basis, nursing empowerment. And we have, empowerment as not giving power. It's not that, it's something that we need to always remind the multidisciplinary team. And it's about strengthening autonomy and sharing knowledge and encouraging leadership of these nurses so that they're able to feel comfortable about speaking about their concerns and doubts without being judged. This is very culturally difficult here in Latin America, and we've been trying to change this. And a practical example that we've been working on with the doctors especially is that, for example, instead of them going there and change a vasoactive drug, that they are able to explain to the bedside nurse what they're thinking and why they're doing that. When a fellow comes to talk about the surgery, that he teaches them what's expected, what it is that happened in the OR and what was done for this patient. We're all educators, every professional. And that kind of daily knowledge sharing have been sharpening our nurses' critical thinking and involving them more in problem solving. We noticed how much even the nurses that are doing this for a long time, that they need to improve their knowledge. And that's why we created a pediatric cardiology nursing post-grad course in Brazil. This, with the support of Children's Heart Link, with our institution, we've been giving them scholarship opportunities. And we used a lot of our Children's Heart Link volunteers, what they taught us, as well as the PCICS resources that they have available to implement in the curriculum. And the nurses always talk about how much more confident they are, how much they feel more effective in their roles and supported by the medical team. So in Brazil, we have more than 130 nurses already trained, and in our unit, more than 20% are certified already, and we can see the positive impact for sure. A little bit of our story, with our data is that we have, even though we have more procedures and more complexity of our patients, we've been able to increase our infection rates and our mortality rates. And we're very thankful to Children's Heart Link, international database such as IQIC, and the networking educational opportunities that we have through PCICS as well. So who is PCICS? And that's what I'm here to talk about, a society that I'm very passionate about, and how they have been able to help our nurses in the multidisciplinary team. So it is an international professional medical society that aims to empower diverse global community of pediatric cardiac critical care multidisciplinary team. They're all dedicated to improving the lives of the patients and the families. I have been a member since 2018, and as a nurse, I was able to participate in the international committee and as a co-chair of that committee. And through that, I was able to bring so much knowledge and change various protocols here at our service. And they have definitely helped our results. Also, I have been able to share that content through books and through meetings with our nurses and the post-grad course, like I said. Some of PCICS core values: reverence, which means respect and passion for patient care; knowledge, so they advance healing through education and inquiry. They offer so many great resources, educational opportunities through lectures, webinars. They have amazing APP courses and boot camps. We're able to participate in special interest groups with people from all over the world and great hospitals where they share their clinical protocols, and they're able to talk to us about our doubts here in low and middle income country issues. And this has been very great to participate. They have amazing meetings that focuses on pediatric cardiac intensive care for the whole multidisciplinary team. The core value of equity, which they build diverse and inclusive professional community. And I'll explain a little bit more about how they're expanding that for other chapters around the world. And connection, like I said, creating opportunities to build relationships that support professional growth, a sense of community, collaborative patient care. It is such a great place to meet extraordinary professionals from all over the world who are extremely dedicated and passionate about pediatric cardiac intensive care. So their goals with the international expansion is to ensure a truly global community of pediatric cardiac critical care professionals. This means recognizing and addressing unique needs in different regions, working to provide accessible resources and to support growth and training. Another key objective is to help shape health policies that support these specialized nursing. So creating regional chapters will be really important, for example, to help develop advanced nursing roles like the APP areas where they don't exist. Like in Brazil, we don't have that yet, and as well as specializing the nurses in that area. And finally, aiming to recognize and value nurses as integral members of the team. We have launched the first chapter of PCICS in March now, just a few weeks ago, Latin American PCICS chapter. And we're very excited to bring all of the great resources of PCICS to more members in Latin America. The next chapter we plan to launch it in the near future is the Asia Pacific chapter. They have a really great podcast, and it's the longest running podcast for pediatric cardiology and critical care. I really encourage you to be a part of PCICS. Here's the scan for you to be a member. You get to network with colleagues, and there's member discounted registration fees to their wonderful annual meeting. They have a huge warehouse of protocols and clinical guidelines that the main hospitals use, and they share that with us, and a bunch of leadership opportunities like I mentioned already. So I invite you to be with us in Austin, Texas at the annual meeting for PCICS. These are some of the amazing professionals that I was able to meet through PCICS. They inspire me daily to increase opportunities for nurses in Brazil and in Latin America. So thank you very much for the opportunity to speak about this here.
Thank you so much, Bruna. Wonderful presentation about what one society can do, and especially specialized nursing. I think it's very interesting how the Pediatric Cardiac Society, Pediatric Cardiac Intensive Care Society has decided to grow from outside of North America, where we know that this field of medicine is mostly concentrated in North America, Western Europe, and Australia and New Zealand. And so to grow the number of people around the world interested in this field and learning more about this field has really been the goal of the society. So thank you for sharing about your story and about their story. So we'll move to our next speaker. speaker, which is, I think our next speaker is Natalie Pattison. And so Natalie will speak about the experience from the NHS about nursing planning, nursing forecasting. And I heard Natalie speak once in a previous webinar, and I think she was a fantastic story to tell. So Natalie, the floor is yours. And we, again, will put your bio in the chat for everyone to read. Thank you so much again for joining us.
Thank you, Bistra. And today I'm going to be focusing more about staffing policies from a European perspective, because I think previously I presented some of my research. I'm going to give a couple of slides on the research, but I'll focus more on the broader picture just to give people a sense of some of the issues that we face. So I thought I'd just give a quick overview around the state of play in Europe, because we have a very, very mixed picture around staffing. So in some areas it's legislated, and we're very fortunate that we have the, oops, sorry, I don't know if it's still sharing. Are you able to still see my screen? I just tried
Yes,
to...
yeah, we can see it very well.
Sorry. So yeah, I was just saying in some countries it's mandated under law and you cannot change those numbers. And this is for ICU, but it includes pediatric ICU. So in the UK, we are known for having a one-to-one policy, but I will say in reality, it's very rare that we get a one-to-one, that it might be a 1-to-2 for a level 2 patient. So the sickest patients get one-to-one, and the patients who might have only 2 organ support will get a level 2. They're classified as level 2 and will have a 1-to-2 ratio. But we find in the UK that's not routinely upheld due to those chronic staff shortages. And that's not just the case in the UK. That's also the case in Latvia. They also have trouble with maintaining those ratios that are recommended. Our Pediatric Critical Care Society recommends each PICU bed has a minimum of 6.4 nurses per bed, but actually it now equates to 7.01 nurses because they now account for maternity. This is quite outdated data, so we've been doing some work on this nationally, and I was the chair of the UK Critical Care Nursing Alliance when we published our work, the Workforce Optimisation Plan, where we published data around how many ICU nurses per bed should be available, and paediatric critical care are also very much part of that UK Critical Care Nursing Alliance. So we've got some national guidance now, but we're still in that situation where it's not mandated for us, unlike in France and Germany, etc. And as you can see here, we've got quite a wide variation up to the Netherlands, where it's up to 1 to 3.5, which is quite a high number of patients to nurses. Similarly, in Belgium, it's mandated, but actually we've got a very high number of patients to nurses. So a lot for us to work on, and we have a very mixed picture across Europe. So obviously in Europe, you do have European-wide guidance for NICU around nurse staffing in neonatal intensive care. And we've got the European, and that's come from the European Standards for Newborn Health. And I put the link here in case anybody's interested in that. But we don't have European-wide guidance for PICU. That is a piece of work that, probably can sit within broader pieces of work around critical care. But I think there are nuances within PICU that warrant specific guidance. So more broadly, what do we know from the numbers? So as part of some of the work that our team did around the seismic study, and I'll briefly touch on that in a minute, we undertook a systematic review around the associations between nurse staffing. So we reviewed all the evidence, the quality of the evidence, and notice that where you do have lower levels of critical care nurse staffing, as we know, it does increase not only mortality, but also things like hospital-acquired infection, hospital costs, lower nurse perceived quality of care, and family satisfaction. We know from a plethora of data that mortality proportionately increases with a reduction in nurses. And policy is really important because it prevents institutional abuse of nursing ratios and ultimately burnout and retention, etc. So this is the seismic R study. This is a study that I've had funded. It's a very large study across many centres in the UK. And it's a study to evaluate the introduction of new and alternative staffing models in intensive care. And it's a realist study. So a realist investigation looks at plausible mechanisms and develops program theory to understand what happens for whom, why, and when. And this is funded by our government arm of the research arm of the NHS. So that's a government funded piece of work. And ultimately, what we're hoping to do is to identify the key components of optimal staffing models for deployment in ICU. I will say this is adults, but I've been working closely with paediatric colleagues, and we're hoping to maybe even replicate the study in pediatrics. So we undertook a survey that's just about to be published. It's been accepted, and that's around understanding what staffing models are in place. So post-pandemic, we saw a lot of change, and there was a lot of pressure for people to retain those really stretched ratios that we all worked to in the pandemic. But gradually things have returned to normal. So that data's out there to help us understand what the state of play is. Again, we've got a high number of, vacancies, a lot of turnover, etc. So we undertook detailed case studies across 13 ICUs, and that was 6 sites and a lot of interviews and ethnographies there. And we developed these program theories. We've also done a large-scale data linkage piece. So we linked patient outcome data, and this is from a national minimum data set that's commissioned by the government. And we linked data there, and I'll give you some figures shortly for that. And then we've also done a really interesting piece, which is around simulating, so that we could see, without any impact on, real-time patient, what happens if you change the staffing policy. So you change ratios, say from 1 to 2 to 1 to 1.8 or 1 to 1.5, and what impact that might have on mortality. And we've got fairly large numbers here to be able to do that. So as you see, we've taken over 1 million shifts and a very large number of patient admissions, done the linkage across those to be able to understand, what's happening in terms of the amount of hours per patient day that are being delivered, the amount of care hours per patient day that are being delivered to patients. And we've linked that across a number of admissions. I'm not going to go into the details of that. This paper has also just been submitted, so this will be coming out very shortly, but I'll kind of talk more now about the broader picture and some of the work that my colleague Orsola, who is leading this webinar, has done around the EPOC study. So this is based on data from a large set of trials, but I thought it's really important to bring this out because actually this is focusing on pediatrics, and we really don't have any data in this area. And you can see here again, where you've got a high number of patients to nurses, you get worse outcomes. And this is really important for us to think about as we're going forward. So where you've got those 1 to 3 ratios, this is not great for patient outcomes. And the more data we get like this, as was talked about in previous things, it's really important that we build that evidence base to be able to articulate why we need the ratios that we need. We can see it's not only that they get higher mortality, but it's also actually the quality of documentation is worse. Nurses can't influence care. They can't call for help out of hours. It's worse quality communication and timeliness of care. So it's a really great piece of work that Orsola and her colleagues led here, and we need more work like this, particularly in paediatrics. And there is work out there, as some of my colleagues have already attested to, and I'm just highlighting a few of these, great pieces of work that have been published in the last few years around paediatric intensive care staffing. And there is a thrust towards that move away from, the care hours per patient day to more of an acuity model. And I'll talk through some of the different models very shortly. But I guess, and this is some work based on some quality improvement work by Marshall Stevenson and colleagues, where they look to see actually, can we get a good prediction in terms of working towards a more acuity-based model per PICU nurse compared to using care hours per patient day. And you can see here where they did move to an acuity-based staffing model. Actually, they had a reduction in reportable safety incidents. Now, this is only a QI study, but it's still great data in terms of getting things out there. I guess what we do have to think about, though, and thinking about things like the Cameo tool, is does it sufficiently capture the patient dependency? So here you can see the Cameo tool. This might be a little small on your screen, but essentially what I'm wanting to highlight here is that actually it doesn't really capture all that we do. And this is my biggest plea to everybody, is that we really need to articulate what it is critical care nurses we do, what care it is we deliver, and how that is sometimes reduced in some of these models to a very, very limited set of metrics that characterize what nurses deliver. And that is a little bit of a problem for me. So going forward, thinking about, what it is that we use. They're often the ratio-based models, the acuity, dependency, or task-based models. And there's some of these models here I've just briefly articulated. So we've got, specific ones for pediatrics in the UK. We often use now the Cameo tool as well, because there is probably really the only validated tool for pediatric ICU. But I'd welcome any thoughts around that as we go forward. But some people are still using those, nurse per bed models, the time task activity approaches, professional judgment. And actually a really big study has shown that professional judgment is superior to some of these models, which to me is fascinating. And again, some of my work touches on this. And I guess for me, we have to think about what it is that we are really trying to understand in using these models and how they might determine our policies, when actually professional judgment, is something that we still must champion. We mustn't lose that in our furthering of the evidence base in all of these areas. Some of the key factors are that, we still see that there is inconsistency in staffing management, and there is no intervention studies really to guide deployment of staffing in critical care. And there's no evidence really to support one staffing model over another. So we've got to gradually build this evidence base, and that's what, some of our program of work hopes to eventually achieve. And I wanted to, again, just mention this kind of concept of the invisible work of critical care nurses. How nurses undertake the organising of work is often hidden. People don't understand that. So we might do a lot of very complex sense-making, interpretation, checking, understanding how we locate that information to be able to guide our care delivery. But actually, that is not captured in any of these tools or in any of the models that we talk about. And we have to kind of, balance that need to deliver the technology, which might be captured in the tools, and that caring, which incorporates all of this invisible work that nurses do. It's not easy to forecast demand, and that's why we need these models. And, there was for those of you who are at EPNA, there are a great couple of presentations around looking at things like the PNAS, which is the Nursing Activity Score for pediatrics. And it looks like actually, that has some indication that it might be better at predicting mortality of the children than NEMS and TIS. But again, for me, it's how does that translate into policy use to guide staffing? Some other Norwegian work looked at whether the NAS could be also used to predict workload variation. But again, that was only able to predict the next shift, no further on than that. And again, what's the value in that in helping us to guide staffing? So we need that new evidence, and how do we use those evidence then to shape policy? There's some really great work. Again, I put in the Curly model. I know Curly's already been talked about this afternoon, but I thought I'd just bring up this that she did just to kind of, or she led to kind of help us think about the real breadth of things that we need to think about, and that complexity in terms of developing these nursing metrics, to think about what it is we do and where the patient sits within that. Ultimately, we need to find those optimal ways of matching demand, patient need, and available skilled workforce. So where does the future sit? I know that some of my US colleagues, for instance, are using, AI around staffing. We certainly got asked whether we would consider that when we went for our very large study. But I suppose where we are with that is that we don't really have good validated models at the moment around what they should, look like. There's that black box phenomenon where you put rubbish in and you get rubbish out within AI. And it has to be underpinned by very good science. And yet a lot of our quality improvement colleagues are wanting us to use AI without the evidence to underpin it. We also have to think about those policies in extremis, like the pandemic. What do they have to offer us for thinking about general practice, and what can we do in everyday practice to learn from what happened in the pandemic? And I think, we will encounter another pandemic most likely in our lifetimes, and we have to be prepared for that. Think about how we build those policies, but we need strong leadership. And for me, that needs to sit outside of government to help hold people to account for those decisions made now. And I think that's why it's so great being on this call to understand, that actually having that professionally led policy will really help us drive that forward and to clearly define what it is we do. There are lots of great pieces of work out there. A couple I'm just outlining here around where the future of AI is around staffing. But again, I caution that we do need to really think about, going back to those fundamentals. What is it that we are asking, and what is it that we are actually expecting to be measured? So I shall pause there and say thank you very much. Thank you.
Thank you so much, Natalie. Again, fantastic presentation. Lots of food for thought, especially when you start talking about AI and how we use AI for forecasting. And I have also a million questions, but how do you use this in a not non-public funded or universal health coverage system like we tend to have in the United States, and many countries are actually developing around the world. So we have a couple more speakers, and then we'll open for questions. Our next speaker is Natalia Henao. Natalia is from Colombia. Again, someone with a lot of experience in pediatric intensive care. You'll read about her work in the chat box. Natalia, the floor is yours, and we'll go for questions after the last speaker.
Hello, thank you. Pleasure to be talking today about a topic. This is essential for the improvement of pediatric intensive care and the health of our children. And I'm sharing my...
Yes, we can see the first slide.
Thank you. In Latin America, in the region of America, there are 7 million, which represent 56% of the nursing workforce, and only 70 are association with some union. If we think 2 million professionals, it seems an important number, but when looking at the distribution of characteristics appears that is a repeat in different areas, and that is the disparity. Most Latin American countries are well below 30 nurses per 10,000 inhabitants, and which will be expected is very low in the so many countries for Latin America. Nursing, when review the age distribution, it can be seen that the most nurses are under 45 years of age, and which tells us about a young population in many cases with a little experience. More nurses and professionals are women. 89% of this workforce is women in Latin America. And the migration and qualified human resource has become a situation that makes it very difficult to advance in the number of the nurses in the region. Colombia, Peru, and Venezuela are the main countries of origin, and Germany and Spain are the main reception to principal receptor, and is a common or an increased situation for Latin America. 31 countries wide storage, and this situation based on the fact with storage and personal high migration and difficult working conditions that led to desertion. It is estimated that in 2030 will be a storage shortage on 2 million nurses in the region for 23. And when the formation, 30% of nursing programs are located in Brazil and in the United States. And the 6 doctoral training programs in Latin America, 60% is in Brazil, but the other countries in Latin America have a low resources for formation. Specific in nursing practice advanced, some countries have advanced training in pediatric intensive care, wherever in most of them, nurses do not receive economy or labor recognition for it. Only in some Latin American countries we can find nursing association specific in the area of pediatric critical care. And when I go to the different formation, disparity in training, legislation, and resource is the more common. How the critical care nurses experience care specific and close to the bed or the patient, have disparity in the formation of teams, high level of nursing technicals in chair of direct care, much of the nursing time with administration and other responsibilities, and perception for the nurses is have high workforce. And this study compared to different perception with the teams, with the different ways thanks to the experience based to the assigned responsibilities, because the policy is not the same for all critical care staffs. And in this study, the group care for more advanced nurse have very good results, and it was perceived as holistic, comprehensive, and empathic. Whereas in the UC with the prevalence or delegation care to a technical nurse, this was related for the nurses and have more work administration, leadership, and management of the UC. Regarding the results, is the care direct bedside care by nurses showed better performance in patient safety and was closer to the skill level and legally responsibility of the nursing staff. Have any opportunities to improve Latin American performance in critical care, like a national policy and plans for human resource, interprofessional and competence-based education and collaborative practice, development of faculty, encourage monitoring programs, increase regional research, and lifting learning, improve working conditions, regularity update, implementation of the role of advanced practical nurse, and advancing cooperation between countries. Thank you.
Thank you so much, Natalia. This is a great quick overview about data from PAHO and, specific example from Latin America. I think it's important to keep in mind that we have regional differences, even though the problems seem to be the same across the world. But the one number was striking to me: 83% of the nursing training programs are in Brazil and one other country. I think this is just shocking. In the United States, right? That's just shocking, and it's something that obviously needs to change. So I think you're introducing our last speaker.
Yes. So I'm going to introduce Anne-Sylvie Ramelet. Welcome, Anne-Sylvie. Anne-Sylvie is, as you can see, a full professor and leading the PhD program in Lausanne, Nursing Sciences, and she's also the SPNIC President-elect. So welcome, Anne-Sylvie. We look forward to listening to you.
Thank you, Orsola, for this kind introduction, and I will share my screen. Can you see my screen? Yeah. In the right mode. Sorry, because I have different screens. Just wanted to make sure. So, yeah, well, first of all, thank you, WFPICCS and the organizing committee for inviting me. It's an honor for me to be here with you. I basically talk on the hat of a nurse consultant of ICN, and I will talk to you about my mandate that I have with ICN and working with PMNCH, which is a network of global leaders for advancing women, children's, and adolescent health. The PMNCH has 4 different missions. One that is focused on maternal, newborn, and child health, and that's where my role is focused on via constituency, but I will talk to you about it a bit later. And they also have a mission on sexual and reproductive health and rights, adolescent well-being, and also what they call cross-cutting areas where they have a specific focus on fragile and humanitarian settings, climate change, economics and financing, and of course, how to react to pandemics and health emergency. So these PMNCH, 243 partners from 131 different countries, and you can see on distributed. And on your left, it's organized within a different constituency that you can see listed on the left. Most of them are represented by non-government organizations in green. And the constituency that we are interested in today is the Healthcare Association constituency that represents only 6% of that network, but it's a very important constituency. It's multidisciplinary. It's constituted of the International Council of Nurses, also the Council of International Neonatal Nurses, COIN, that is also a member partner of ICN. There's the International Council of Midwives. We also have the gynecologists and the pediatricians from FIGO and IPA. So we always say, together we are stronger, and we are representing like the voice within this large network of leaders. We are representing the main healthcare professionals for the care of women, children, and adolescents. And 2 years ago, in 2023, there was a theme on World Health Assembly that is every year, the World WHO organized. And in 2003, the PMNCH asked or made a few demands to basically make healthcare services stronger to better meet the needs of women, children, and adolescent health. And this has been the work of 2 years, and there's an advocacy brief that hasn't been published yet by WHO, but I got the permission to actually share a few insights from it today to you, so it's quite a heads up, really. And I'm going to go through this policy brief and advocacy and how we can address these issues to human resources and workforce. So why is there's an urgent action needed? I think it's been covered in the previous presentation before, but this is really focused on children's health and adolescent health. But the previous speakers talked about the significant disparities in education, distribution, performance. And Natalia, you showed that quite well in your slides, as well as the brain drain among HCPs And that leads to a huge unequal distribution of nurses around the world. And because pediatric is already a specialty, pediatric nursing, and pediatric intensive care nursing is even a specialty. So all this effect actually touches all nursing, but it's exponentially impacting our specialty of pediatric critical care nursing because there's less regulation, and also the volume is much less. Also, we know that currently globally, the workforce in this area can meet 75% of the demand globally. So it's not 100%, it's 75 already, but it's actually covering only 41% in low-income countries. So I think this webinar of the World Federation WFPICCS is a good opportunity to show like these disparities. And we do have, high-income countries do have a responsibility for this. And we will talk about it later in terms of workforce. And, it will not get better. The official development assistance will decrease by 37% from 2023 to 2027 this is what is expected following, the latest geopolitics, what is happening. We all know that it touches mainly women and children. So we have to keep fighting, I guess. And because we do know that when we invest in women, children, adolescent health for equity, long-term health outcomes, and healthcare services efficiency and the economy and society at large. So how we can address these issues, it has to be at different levels, high level at government and parliament, UN agencies, to the private sectors, donors and foundations, and civil society. But also, we can do a lot at our level at healthcare professional associations and clinical level and institutions, academic research and training institutions. So I will only present a few points that I think are relevant to us or the audience who is here in this webinar. But at government and parliament level, we have to be engaged, every single individual through the national healthcare professions can actually lobby and be engaged to try to lobby the own government and at parliament. So an ethical recruitment practice is important, especially, in high-income countries. They have a responsibility to hire from low middle income countries because it's a vicious cycle. And, the more we actually brain drain out the competencies, the more disparities we have and the more the problem is. We also have to make sure that health workers, including nurses and midwives, are in leadership and health policy discussions. And that can be, for instance, by appointing, chief nurse officers that are in several countries, but by no means all of them. Also, we need to make sure that government secure funding for safe, well-resourced health systems, not just for recruitment, but also for retention, and also to adhere to global health workforce standards. And we also talked about before, having, I think Lisa Little did talk about having good records to be able to provide evidence to lobby where we have to lobby to influence policymakers. And the Healthcare Professional Association, they are very important because they are the voice of nurses, nationally at country level and or regional level, and even more widely, like WFPICCS. And, they are very well positioned to provide clear roles and skills among healthcare providers, advocate for good standards, amplify the voice of nurses to promote leadership, provide education for leadership. ICN has a great program of leadership, actually, and also, strengthens the association as experts to enhance, training, education, mentorship, research through, guidelines, statements, white papers, policy briefs, etc. But at your level, or my level, actually, we can be, you be a member of your national nursing professional association, be a member of your specialty association, whether it's at national, regional, or wider. Engage, and I guess, I preach, an audience that is already convinced because you are here at this webinar, but talk to your peers and colleagues around you. Engage early in your career and also be an active member and use your voice to promote leadership. And for those who are involved, and I know a few participants are engaged in academic and research institutes and universities, use your voice and leadership to make sure that the institutes and the university invest in good quality pre-service and continuous education for pediatric. Because, like, for instance, in my country, in Switzerland, the general practice, there's very little pediatric training, and we don't have a pediatric specialty anymore. We are working towards it, but and we are a high-income country, so it's pediatric is really like the poor parent of education worldwide, and there's a lot of disparities across countries, of course. Update curriculum to make sure that we target the right disease. We discussed, acuity and how we can measure the nursing care demands in the previous presentations, but the care demands does change. In PICU, we see a much more chronic, critically ill patients who don't have the same demand. So that needs to be, all updated and taken into consideration. The length of stay increase as well. And also make sure that you work in interdisciplinary education, because I think it's the way to go today. So my take-home message really is, we can do it, but it needs to be done at different level of the society. And whatever level you are at, whether you are at your career, you always have a voice and use it. And I also wanted to promote the Congress of Helsinki. And we do have a PICU leader who is a keynote speaker among many other great keynote speakers. If you can, and I really encourage you to go. They are really great congresses. And we also have the ESNIC Congress coming up in Alicante in Spain, if you want to join us. Thank you so much.
Thank you, Anne-Sylvie. It's really very, very interesting talk. And so we were wondering if there were some questions.
And maybe I can start also with a question for some of the speakers. And I would say, before we encourage everyone to send questions to the chat now. And Sylvie, maybe you can stop sharing so we can see everyone on the screen. Thank you for the wonderful presentation. Yes, tying everything together, I would say.
Is that okay?
Yes, this is great.
Okay.
So my first question is for Lisa, Tiffany, and Lauren. And actually, to some extent, Anne-Sylvie as well for you. So I speak, like now, I'll say it, I speak as an advocate for nurses. I'm not a nurse, I'm not a clinician, but I believe in nursing care and believe in nurses. And I really think nurses have been the overlooked health workforce. What has been your experience in talking to policymakers or hospital administrators about specialized nurses? I feel that is still so misguided and misunderstood. I walk into hospitals and I hear the nurse from, I don't know, the cancer unit was just posted in the pediatric cardiac ICU, or vice versa, and nurses are moved around almost like they're a piece of equipment or furniture. How do we change that? I mean, that's still clearly, we all believe this here, that is the right thing to do, but how do we change that at this higher level? I think at the higher level, that understanding is still lacking. So I'm just curious, I don't know, maybe Tiffany and Lisa and Lauren can comment, and then Anne-Sylvie. And quickly, because we don't have a lot of time.
And Natalie has lifted up her hand.
Oh, okay, sure. Yes.
You're all welcome to, go ahead, Lauren, and then Natalie.
Thanks for that great question. It's really, really important. And I think the call to action paper that looks at how do we get nurses from being invisible, I think is going to be very important work when we're able to very clearly identify what nurses do that contribute to the bottom line. Right now, nurses are part of the bed rate, right? So we know an ICU bed, patient in an ICU bed costs, I don't know, pick your poison, $5,000 a day. That also helps to pay for the nurse. But what is the nurse doing that contributes to that? And until we have more clear delineation of the nurse's contribution to the outcomes of the patients, that is not just part of the bigger story, then nurses will remain blinded to the C-suite, even though employees are the biggest cost to the bottom line of the hospital. So it's very important work, and I look forward to ending my career having done this.
That's a great answer. Anyone else want to answer that?
Natalie has her hand.
Natalie, yes, Natalie.
Please.
Yeah, thank you. I was just going to mention some work that Harley Whitaker, who was president of the Pediatric Critical Care Society in the UK, led around what was the experience of pediatric critical care nurses being moved, exactly as you just talked about, Bistra. And actually, we do have national statements saying that nurses should not be moved, well, certainly for critical care, because we wrote them for the UK CCNA, including paediatrics. They should not be moved out of their specialist area, and gave reasons why, and we sent that to all the chief nurses, etc., in the country.
Anyone else want to comment on that? I think Lisa, I'm sorry, you have. Oh, and yeah, Lisa, you have your hand up.
Lisa first, yeah.
Yeah, and I apologize. My internet says it's unstable at times. So, but I think in general, I don't think there is a real valuing of nurses and a valuing of nurses in specialty areas of peds critical care. Like we saw in the pandemic, people thought they could just move nurses everywhere, and nurses and nurses and nurses. That's the common language, I think, by employers and policymakers. And I think for me, it comes back to what I talked about, those nursing sensitive outcome indicators, and what a lot of people have presented here today. What is the difference that nurses make on patient care quality, and then taking that to the economic level? When you can take it to the economic level about what that costs a hospital in a year by using this certified nurse versus any nurse, that is what makes a real difference. And that's what speaks to them is money. And I think capturing data about that and I'll put a plug in for, the ICNP, the International Classification of Nursing Practice, that's now embedded in SNOMED, in electronic health records, that we're now going to be able to mine that kind of data and use AI, as was alluded to be able to pull that kind of analysis and do that predictive to show in a real robust way. Most of our data is not captured in an electronic health record, right? That's attributed to nursing or nursing specific in a particular unit with critical care nurses or whoever. But I really think it's about that direct link between nursing actions, patient care, patient outcomes, and monetary is where we have to go.
Thank you so much, Lisa. That's a great point about electronic medical records, wherever they have them. And I think more and more hospitals I see having them, but absolutely, I think that's a very good point. And Sylvie?
Yeah, I mean, I can compliment on what Lisa just said. One of the problem is, the health record needs to be pediatric tailored, because for instance, the DRGs, they are adult, they are based on adult data, and they are absolutely inappropriate to describe pediatric nursing demand. We are currently, doing a project on this in Switzerland, because we are a small country and the most pediatric services are in adult hospitals, with a structure and financial structure for adults. And we always have to fight for why do we need more nurses for, the patient to ratio, for instance. It's really every day we have to explain why we need more nurses to do the same thing in children. But I think, for the specialty, there's a very good, this has been, like the Bible for us in terms of clarifying the different role. What is a general nurse? What is a specialist? And what is an advanced practice nurse? And ICN has a document that is very well. And that has been really our Bible to define our curriculum, education curriculum for the nurse practitioner program, for instance, for the clinical nurse specialist program, and also to inform different studies when we look at the roles, even like for the nursing care demands in pediatrics, we are using that differential. And it's only by documenting it that we will be able to, like Lauren said, to really have strong evidence and data to put structure in place that where, all this problem will be avoided, where, we always have to fight for staffing, that we are not recognized, and, we have to replace 2 adult units, but the adults never come to pediatrics because it's way too scary for them.
Yes.
Wow.
Yeah, all of those great comments. Go ahead, Orsola.
Yeah, no, great comments, and also a thought that there is lots to do in terms of outcomes and studies in pediatrics, because there is not enough. It's a cost effectiveness studies. So where do we go next? What do you think is the next step that we should take? So as WFPICCS members and a group of people that is particularly interested in making pediatric critical care better and safer place. And so what do you suggest? There's lots
Well, that's a huge question, Orsola.
I know it's huge. It's huge.
Yeah, I think this is a really, I think it's a really great start to be here. And as I've participated in WFPICCS in the past, getting people together to just have the conversation, I think, is a really important place to start. I think individuals in hospitals across the world, and I learned this over the last year as president of FCCM, we all share the common problems. Contextually, they're different though. But the issues of lack of recognition, staffing, floating, education, all the same. So having an understanding that it's the same everywhere, but different in your country, again, the context, starting to build coalitions, I think, within your country, I think is where to go. And so identifying who those people are, where you live, to start building those coalitions, to really get a grassroots groundswell effort to begin moving the needle on that. And that feels very overwhelming, I think, sometimes to do. But places like, or organizations like WFPICCS and FCCM and PCICS and SPNIC and all the other groups have leaders that are willing to help start doing some of those things, or at least help you start thinking about that. So I offer that as a place to start.
Well, one thing that I would suggest, thank you so much, Lauren. Great comment. I sincerely appreciate the involvement of ICN and in this topic. And Sylvia, I appreciate you talked about the Partnership for Maternal, Newborn, and Child Health, because these are organizations that can advocate a lot for specialized nurses. And so perhaps we could come together and write a policy brief about this topic. I would be very happy for us to provide support for that. I don't know, Orsola, do you want to share any additional thoughts?
Yeah, no, I think Bistra, this is a great thought of yours, because it could be very useful. As Lauren said, we have the same problems worldwide. I mean, it's nothing new under the sky, and but getting together, and whether it's a policy brief or, joining forces and ideas and starting at the local level, but also at the international level makes sense. And so we do have a platform here where we can exchange ideas and share resources and so on. Nancy, go ahead.
Yeah, like the policy brief that I started to share today, will be published by WHO, endorsed by WHO first, and then will be published. It's, it can be, a starting point, because it's focused on maternal and child health, but it could be, it's very broad as well. So maybe it could be a starting point to draft a policy brief for pediatric, critical care.
Wonderful,
and
thank you.
Contextualized based on all the experts that you have here and the others who are not here, to have like an expert consensus meeting or something.
But wonderful. Yeah, sounds like a great action point from this meeting. Yes. Any other comments?
If you give me a second, I am going to put in the chat a survey that is part of the call to action paper. There's a survey that people can complete to identify whether or not people agree with the 9 domains and whether they think they're relevant and how important they are to the work that we're doing. So I'm going to post that link right now.